We have Dr. Sammy Noumbissi. He obtained his doctorate in dental surgery from Howard University in Washington, D.C., was selected to attend Loma University graduate program in implant dentistry. There he received 3 years of formal training in dental implantology, which culminated with a certificate in implant dentistry and a Master of Science degree in implant surgery. He is a researcher, author, and has published book chapters and articles on ceramic implants in peer-reviewed dental journals. He is a visiting professor at the University of Milan, Italy, and visiting researcher in materials department at INSA Lyon in France. Dr. Noumbissi is the founder and current president of the International Academy of Ceramic Implantology, which is an independent association focused on metal-free and ceramic implantology. He is a fellow and ambassador at Clean Implant Foundation, whose mission is to assess production, quality, and purity of commercially available dental implant surfaces. Dr. Noumbissi has been practicing and educating dentists on metal-free implantology since 2009, and his practice is located in Silver Spring, Maryland. All right, so please give a warm welcome to Dr. Sammy Noumbissi.
Thank you. Thank you. Okay, good morning. It's nice to be around people again. I think the last time I was anywhere was February, March, after the ceramic meeting in New Orleans. I think most of those who were down there, you remember we got out of there by in extremis, like they say in Latin, right? I don't think anybody got anything from being there. That's good. I think it's due to our lifestyles and how we approach life in general. The world has been stressed a lot, but okay. So I'm here this morning. First, I have to read this, yes. I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. Okay, so I'm here for the IOCI. I'm not speaking for any company. I'm not being paid to be here by any company. So I'm going to show you a range of things from my perspective, and hopefully you'll be a little more enlightened. So the title of the presentation is Metal-Free Ceramic Implants, How Far Have We Come? Well, we've come a long, 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 long way. A lot of things have changed. But for this to happen and then eventually change, you need to have certain people. There's certain people that were there in the beginning that allowed us, or allow people like me, to be able to even openly speak about this and to be able to be comfortable to talk about it, because they laid the foundation for us. And there's a few, but the most prominent one is Professor Sandhaus, who we unfortunately lost last year. And he actually attended one of our meetings 3 or 4 years ago in Florida, in Miami. And it's if there weren't people like him who persevered and believed and pushed, I won't be standing here talking to you about ceramic implants, okay? So, Professor Sandhaus started in the 60s. He developed the CBS implant, which was a crystal bone screw implant. That's in 1960. Then in 68, he commercialized another design of his implant, which was called a Sigma implant, okay? And then in 1974, he came with another version of it. You see, keep trying to improve it. 14 years in, the InsaMed. Then in 1987, he had the Serasand system. So these are people who were out there persevering from the 60s to the 80s and all the way into 2017 when he came. He was 91 years old there. So he was gracious to accept the Lifetime Achievement Award, the only one ever given on ceramic implants and by the IOCI to anybody. So we were very fortunate. And just to show you a little bit an idea of what he was doing, these are the different versions of the ceramic implants he developed over the years. So, like everybody, he started with a one-piece. Actually, he started with a two-piece. And the complications that come with two-piece and the materials that were used at the time, and I'll go over that. They were ceramic, but they were a little different. He went to a one-piece and went back to a two-piece. Because all of us who do implants here know that a two-piece is a lot easier to place, to restore, to manage over time. So that's for my tribute to Professor Sandhaus. Really, we have to be thankful to people like that. I always tell the people what brand mark is to titanium, he is to ceramics. That's simple. So, dental implants, everybody knows what the dental implants is, but I just want to lay some foundation so that we don't get confused. It's a permanent implantable biomaterial. Even a bone graft is considered an implant. But here we're going to talk about a root form implant, which is a root replacement implant, so that you can place a crown on it. It's surgically inserted to the jawbone for dentists. For the foot guys and the orthopedic guys, it's into the toes and all kinds of other places. And it provides a base for various teeth replacement solutions. Singles, bridges, full arches, you name it. So there's some other things that go also into defining a dental implant is we place them and we have pretty much taken it for granted that they're always going to integrate without any problems. Okay? It's almost like a given. When it fails, we are so embarrassed about ourselves, which is, I don't know why we do that to ourselves, but you know, we are the only one of the few healthcare practitioners who tend to want to guarantee things to our patients, dentists. And there's a good running joke that says the difference between dentist and God is that God knows he's not a dentist. But we think we can do godly things sometimes, which is. But last but not the least is no interference with the surrounding tissue biology or the host health. There's a lot of materials out there that can do amazing things, but are they good for the patient? Can the patient accept these materials without any problems? Okay, that's part one of the things that we look at when we try to define a dental implant. Now, there's three main criteria in terms of the material. One is a chemical composition. What is it made of? Titanium, cobalt, chromium. What is it made of? Then we have what organ does it replace? Because there's different varieties of the same material that are good for a valve or retina, but they're not good for a joint. But it's the same fundamental material. So we have to know what we're trying to replace and what's the best material to fulfill the role of the organ or the part that's being replaced. And again, once again, the biologic response to that material. How does the recipient respond to that material? Because I've been saying this for about 2 years now, there's a lot of materials, especially in dentistry, that are biotolerated. They're not biocompatible. The body learns to work around them or with those materials, but it's not necessarily a biocompatible material. And over time, these materials stress the immune systems and bring a whole host of problems that we all pretty much understand in this room. So, historically, what has happened? From the dawn of humans, we have always tried to, we like our teeth, we like to keep them. It's for self-esteem, cosmetics, function, we want to be able to eat, all kinds of things. So we have tried different materials in human history. We've tried stone, gold, ivory, shells, metals, even stainless steel. We've tried all kinds of materials. And as early as the 60s, we started having things like with cobalt, chromium, which today it's a, it's a no-no. Then vitreous carbon, titanium, sapphire. As you can see, for example, sapphire is a ceramic, carbon is a ceramic, vitreous carbon is a ceramic, aluminum is a ceramic. You can see that over time, there's always somewhere somebody investigating or introducing a non-metal material. So I think knowing that metals are not good for implants has been known for a long time. There was just a difficult time finding the proper formulation of ceramic or non-metal material that would fulfill the function of the part, but also be biologically acceptable to the patient. That's why I presented those three criteria a while ago. So if you look at the three that I highlighted there, you have sapphire. That was the one from Japan, the Kyocera implant. And then you have aluminum oxide. That was this Synthodont, if you believe it or not, it was made by Bicon in Boston. And then, of course, the tubing and implant that gave a a bad name to ceramic implants for a long, long time because of some of its propensity to fracture and things like that. And then you have the Yttria stabilized zirconia that came in the 2000s. And most of us who are here remember these systems. It's a YTZP implant. So, to kind of give an illustration of what I'm talking about, the Sapphire implant were like this. They were basically like little glassy rods. And the problem with glassy implants is, especially in bone is like rough surfaces. So if the surface is as smooth as your glass or a bottle or whatever, osseointegration is very poor and the failure rate is high. Also, because it's clear like that, it's called what you call glassy ceramics. Glassy ceramics are very weak. They tend to fracture. And it's monocrystalline also. It's one crystal. Then you have aluminum oxide also, which is a monocrystal. And I'll explain what I mean by monocrystal a little later. That's the Synthodont that was made by Bicon in Boston, started in 1975. And that's the famous Tübingen implant, which I said gave a really bad name because it had a tendency to fracture here right at the neck. And it was made of aluminum oxide, which is very rigid. It doesn't have flexibility. So there were a lot of fractures, but also a lot of failures because all these three implants had surfaces that were pretty smooth. This was the smoothest with the highest failures. These were pretty smooth. This was also smooth, and you tended to have a higher failure rate. And ceramic, this one, because white poly, because it was Yttria, it still exists, there's Yttria, there's alumina, and there's zirconia. Three ceramics. So they call them ceramic composites. So they put three ceramics that can give the whole certain properties that we're looking for. Here we're replacing a tooth. So we need a little bit of flexibility. We need biocompatibility. We also need, we need those properties. Okay? So, now, today, the materials that we use the most, that are most commonly used, this is the most common formulation of titanium implants. These are gone. Virtually nobody uses that anymore, even in orthopedics. And then you have the different versions of the composites. You have the YTZP, the ATZ, the ZTA. So what you see happening is that even in the composites of ceramics, it's starting to change. You start to have certain varieties because every manufacturer is looking for that perfect combination to have the material that's going to work the best and the longest function in terms of function. Okay, so already we have these, and then there's other combinations in different percentages. So, go to this slide pretty fast. We have three types of designs of implants. You have endosseous, which is what we all know. They're screwed-like. Then we have subperiosteal, which are very rare, that you don't see anymore. Although I've seen a resurgence of subperiosteal because with CAD/CAM design, you can now scan the bone and design an implant over the bone. Before you had to do surgery, make an impression of the bone, close, go and fabricate, open and place it. So this is kind of coming back a little bit. And you also have the transosteal implants, which nobody really uses. I see more zygomatic implants being done these days than having implants going right through the mandible because these were prone to fractures. Okay, these are making a quiet little comeback, not in big time. It's really for extreme cases, and they can be CAD/CAM'd and made into, but they're not ready to be made into ceramics because the neck here is going to be a weak spot and an area of fracture if you ever to try to replicate this in ceramics today. So things change very fast. Now, another thing that has been done with implants, whether they're ceramic or titanium, is the surface of the implant. And there's two types of things that you have to take into consideration. The macroscopic and the microscopic. Macroscopic is like the thread design, the thread aggressiveness. One of the latest implants on the market today, the SDS, very aggressive threads. And you can place it immediately after an extraction, and you get good primary stability. 12 years ago, 11 years ago when I started, there was none of that. There was just threads with a smooth surface, and they were not aggressive enough, and the primary stability wasn't very good. But now you have some systems that have very aggressive threads that allow you to do things like that, like immediate placement and even immediate loading. Okay? The earlier ceramic implants, immediate loading, there's 70% chance of failure of the implant. So you have to protect that implant. So the macro surface is a screw, the anatomy of the implant, and the microsurface is what you do to that surface microscopically, or even today, nanoscopically. Okay, we are at the nano level now. Micro, we just abraded it, or we acid etched it, and we still do that, or you just do a coating. And actually, I always tease my colleagues in implant meetings, and I say, whoever places HA-coated implants, and all the room puts their hands up. I say, well, you're placing a metal implant coated in a ceramic. So don't be afraid of ceramic implants. Okay, so again, in terms of illustration, you guys are familiar with these older implants, and you can see how the threads became more aggressive, and even where this is a Zimmer, where they had aggressive threads and then a basket in the middle. This implant was a little bit of a disaster because that was a big weak spot, and it'll break all the time. They'll fracture, especially if the torque was above a certain amount. But that's to show you a little bit how things evolve. And these kinds of evolutions are happening, the way they happen with titanium are happening with ceramics. Actually, I saw a prototype of a ceramic implant in Europe that looks just like that. And I said, what's going to happen here again? Are we repeating the same mistake? That's a problem we have in implantology. There's too much copy and paste. One company takes a titanium design, copies it into a ceramic, completely oblivious of material properties, and then there's problems because they just did a copy and paste. So that's something that you have to be careful. Not because it looks like what you're familiar with means it's going to work because it's in a white material. So the roughness, again, like I said, is hydroxyapatite, plasma spray, or even aluminum oxide, which also is a crystalline phase of aluminum. Hydroxyapatite, aluminum oxide, all these are ceramic coatings, okay? And usually it's sprayed and you get the roughened surface like that. And at the end, and this is still titanium implants, you can either get a full coating of the implant, and this is where you start to look a lot like a ceramic implant. And why are they doing this? Bioactive surface, lower the corrosion rate. That's a big problem, corrosion. We're going to talk about that a little bit. Bone healing happens a lot faster here. Why? Because it's rough, also, partly. And you have a higher degree of bone mineralization on such surfaces. So the majority of metal implants decided that we're going to wrap the implant, we're going to coat it into a ceramic, and hopefully insulate the body from the metal that's below it. It's kind of like knowing it's a problem, but putting a little band-aid around it so that it continues to be okay. And that has gone on for years and has worked fairly well. But now we have, over the years, we've had more people getting implants because they become more affordable. And so in the beginning, it was a very small group of people that probably took care of themselves a little better because they had the means to do it. But now you have all kinds of people getting implants of all demographics, all social levels. So it broadens the pool and broadens and increases the chances of the kinds of problems that can happen, because now you have uncontrolled diabetics that come in, you have unadmitted people with allergies. They have allergies with their earrings or whatever, but they nor their doctor sometimes realize it's a problem, could be a problem. So there's a lot of little things. So I don't think I'll have a hard time convincing you in this room, because it's still hard to convince some people that zirconia is a ceramic. But I'm still going to go over why it's a ceramic, okay? So zirconia bioceramic, until last week somebody on Instagram told me zirconia, I was applauding somebody's post, and the person said, you know zirconia is a metal, right? And we went on a back and forth on one or two back and forths, and I said, I rest my case because I wasn't going to convince this person. And I've been doing a lot of lecturing, teaching, convincing for 10 years, 11 years. I decided, it's time for people to take responsibility, time to read or educate themselves a little better. You just can't force feed everybody to accept certain things. So anyway, we have different types of ceramics. There's two groups. There's the traditional ceramics and there's the advanced ceramics, which is what we use in dentistry. Okay, like the lithium disilicate for the crowns, the yttria, the alumina, the zirconia, and the composites of any of those above to make the implants. Okay, things like clay and bricks and all that, those are also certain types of ceramics, but it's a different type of ceramic. Okay, now the ones we use for dental implants are these three, whatever the combination is, 10%, 20%, different systems mix them different ways, and they obtain what is called polycrystalline. You remember in the beginning I talked about monocrystalline, the tubing and implant with the AL203? That was monocrystalline. It was just 100% alumina. Now the ceramic implants that you see now, they are composites. They're a mix of these different materials because yttria prevents what is called aging. Aging to ceramics is when the ceramic kind of breaks down and starts to have cracks and breaks, and alumina gives it flexibility. But zirconia is a material that doesn't like humidity. So for it to be stable, you have to have yttria there. So these are composites that confer to the implant certain properties that we want, the desirable properties. So the microstructure of ceramics, it basically always boils down to the glass to ceramic ratio. So you have what you call high glass content ceramics, you have glass with fillers, and you have no glass content. So the zirconia implants that we're doing now do not have glass content. They're just crystals. Whereas the ones that we use for crowns or certain things have a little more glass in it. That's why they give us better aesthetics. Because there's a little bit of transparency to it. The glass gives them that, okay? So that's basically what you look at. Predominantly glass, partially filled with glass, like your composite fillings, and then this is like your full contour zirconia crown or your zirconia implant. So it's crystals, polycrystalline. Okay. So the advanced ceramics that we use to make the ceramic implants, that's what they're made of. It's polycrystalline, no glass content, and it looks like that. Now, the best slide I could find to explain this was a French one. French is my first language. So verre means glass, vitrocéramique means glass and ceramic, and this means polycrystalline. And you get a higher mechanical strength when you're on the crystalline side, and the mechanical strength drops when you go into the glassy side. That's why your windshield will fracture faster than your implant, because your windshield is glassy. Whereas the zirconia is opaque and has a greater mechanical resistance. It's very important to understand these nuances of material, and that's what a lot of people lack, and they don't understand. Because they'll tell you, oh, ceramic implants, don't they fracture all the time? I have an easier time convincing patients that it's not an issue than doctors. But it is what it is. Over the years, things will change. So again, alumina, zirconia, and that's how you get your polycrystal material. So no glass content, polycrystalline ceramics are things like the Broxier crowns. I think some of you have dealt with this, the lava zirconias, the IPS max. Those are the no glass content. And the same formulations apply with the implants themselves. Okay? The ATZ, the ZTA, the hip, isostatic press, and all that. Now, how do we obtain zirconia? Where does it come from? Okay, it's a ceramic, we all believe it, but how does it get there? Because the other name of zirconia is what? Zirconium dioxide. And when you hear neum, you always think metal. Aluminium, zirconium, titanium, yttrium, okay. So how does that happen? Well, first of all, probably should have had this before. Let's agree on terminology. Zirconium, zirconia, zirconium dioxide. Zirconium is the metal, like aluminium. It's an ore. It's mined out of the earth. It's processed and made into zirconia, turned into a crystal. So how does that happen? It happens, if you look at the table of elements, you have titanium, zirconium, they're in that same area. All these metals here are what you call transition metals. These are metals that if you put them under certain conditions, here's yttrium here too, yttrium, zirconium, titanium. When you put them under certain conditions, they transition into a crystalline phase. And so they become ceramic. And that's what is very difficult for a lot of people to understand, that these can change their state under certain specific conditions. So again, the basic chemical reaction that happens is that the zirconium is exposed to oxygen, and then you get the zirconia. Like when they tell you, you open the titanium implant, you expose it into the air before you put it in the bone, and there's a titanium, there's an oxide layer that forms. Well, that oxide layer is called titania, because this oxygen exposed to the titanium gives that layer a very thin angstrom, the oxide layer, which is a ceramic layer, titanium dioxide. Okay? So again, so now when the implants are made, you take all these materials, you put them together, then you compact them, then you sinter and further compress them, and then you get, in this case, hot isostatic press zirconia. Okay, so it's always a combination, like I said, to obtain what you need. Now, one thing you'll notice here is between the particles are much open here than here. That's the difference between something that's prone to crack and something that's less prone to crack. Because a crack to take place and propagate, just like it shows here. Okay, so if it's in the monocline stage, this is monocline, and this is tetragonal. So if it's in the monocline stage, if a crack comes in, because there are gaps, it tends to spread. But if it's in a tetragonal stage, if a crack comes in, right, the formerly squished parts here expand like a bag and stop the propagation of the crack. That's why they tend not to fracture, because they have what is called an airbag effect. So when a crack happens and opens a gap, it expands and stops the crack from propagating. Which, for example, if you go into your car, the windshield in your car doesn't have that. You get that little crack, you keep driving the car for a couple of weeks, and then you see the crack spreads like that. It's because the mechanism in that windshield or that glass to stop the propagation of that crack. And that crack can be caused by many things. Drilling, lasers, temperature, mechanical stress. That's why certain implants tell you don't prep our implant, because they know that based on their formulation, if you prep it, you're going to create cracks and eventually the implant can break. Okay? So again, I'm going to go a little faster through this. What happens, you have the powders, you mix them, you compact, and then you get whatever, you get a block, a little bit like your CEREC block in the office, and then you go and mill them into whatever implant you think you want to make, or your design. And then, after that, like titanium, you have to treat the surfaces. You can see macro and micro. Macro is a thread design. Okay? But you have to roughen the thread and you have to roughen the color. Because as you know, all ceramic implants on the market, well, most now, I think somebody else came with a bone level ceramic implant, which in my opinion doesn't make a lot of sense, but that's my opinion. They're tissue level implants. So you have the color of the implant that's in the soft tissue, and then you have the threads that are in bone. So they're roughened in two different ways. And the roughening of ceramic is usually one of those three. The most popular one is the acid etching and sandblast combination. And only one system does the laser etch, and then some others are still doing sandblasting. The problem with sandblasting is that when you blast ceramic, you can induce cracks. So that's why a lot of systems are staying away from sandblasting the surfaces, because you can potentially induce cracks before you even package the implant. for sale. So that's why you don't see a lot of sandblasting that much anymore. Now, how have ceramics and bioceramics found a place in dental implantology? Well, it started like this. Brand mark days. Implants were metal, shiny, looked like a car part or something, okay? Then we got a little more sophisticated. We started coating them, like I was mentioning earlier. They started to pretend to look like a tooth a little bit. Supragingivally, that's the kind of abutment we started with. Then abutments like that, went to abutments like this. I want to note the transition from this to this was because there was a lot of fractures of this. This was really a silly thing to do because we were matching two materials with two different physical properties. This one doesn't bend, this one can. Well, this one cracked a lot. You know? So that's how then now you see there's a metal interface and then the ceramic goes at the top. So ceramics have been always coming around. So again, it all started with one piece. It always starts with one piece. That's the one I was showing you earlier, the sapphire from Kyocera. Glassy, high failure rate, high fracture rate, because it was just glass. Okay? Then the tubing end. But it was still a monocrystal. This also was a monocrystal. But there was a design flaw here. Tons of fracture at the neck there. And the surface at the time was still smooth. Then these systems came with this. The earlier ones, the first ones that I used, surface was very smooth also. They did a lot better than the others. Again, they were one piece. Then you have CeraRoot, also one piece. They still do one piece. They've not come up with a two piece. They've always kept this implant. I think that's probably one of the most beautiful one-piece ceramic implants I've ever seen. But I don't use it, but it's a very well-designed, well-thought implant. And then Straumann also came with theirs. So you see almost everybody that comes with a ceramic implant always starts with a one-piece. It's the safest place to start because up until recently, you always needed that bulk of ceramic in order to protect yourself from fractures. That's changing because the compositions are changing, but that's what it used to be. Then we go into the two-piece. That's when things start to become a little more easy. And the beauty is that it's two-piece with a metal-free screw, with a carbon fiber screw. That's even better. Because we have patients who come to our practices, they don't want to hear about metal. And some of us don't believe in metals anyway. So it's nice to have now a system that's two-piece. And that also has a screw that's metal-free. The downside of this is that once you unscrew that screw, you have to put a brand new screw. You can't reuse that screw. But I think it's worth the trade-off. And then you have others that also have two-piece, but they're using a metal screw. Again, this bothers me. Because that screw, one, it's metal. Two, it doesn't have the same physical properties as the materials it's supposed to keep together. It flexes more. Now, these are not old enough to know what is happening with them. But I won't be surprised if we probably have a lot of fractures. As a screw gets old and starts to stretch more and flex more, there's a chance. I don't know. It's not FDA approved yet, but they're on their way. And then this is another version. This is an XT from Xeramex also. They make it for Nobel. Nobel has one exactly like that, but it's really a Xeramex implant. So has a metal-free screw, more aggressive threads, very good primary stability when you place them, okay? A different type of connection. Those of you who have done implants for years, this reminds me of the spline from Calcitech. Very stable connection. And this implant is also very nice because now it has angle abutments. So if your implant is a little off, you can purchase an angle abutment to correct a little bit if you're off. Or if the facial profile is a certain way where you need to angle in, they have angle abutments. So that's pretty nice. And then also, of course, Straumann has come also with theirs, which also has a metal screw and even a metal base. That's how they're doing it. That's not my favorite solution, I would say. So why this shift to bioceramics, to implants? Well, the biggest problem is corrosion. And our orthopedic friends have recognized and admitted that this is a problem 20 years ago. And we in dentistry still kind of refuse to admit and recognize the fact that corrosion, the alloy of the implants will corrode. Everybody, I was trained the same. Titanium is the best thing that ever existed. It doesn't corrode, it doesn't do this, it doesn't do that. No. And there's no commercially pure titanium, and there's no titanium that's 100% pure. There's always some nickel, some other things in there. Okay, so, but that's the problem we have. So anyway, so you have different types of corrosions in the mouth. I'm going to focus really only on the galvanic one, because this is something that we're all familiar with. When we were in dental school, they told us don't have gold crowns again, or whatever, dissimilar methods. In implant dentistry, we do that all day long. We have an implant of a certain alloy, a screw of another alloy, an abutment of another alloy, a coping of another alloy. You stack up 4 or 5 alloys in one of the best electrolytes, saliva. What do you expect? But you have different types of corrosions. You have galvanic, stress, fretting, wear, bacterial. Yes, bacterial cause corrosion. Fluoride-induced corrosion. There's a lot of things that can cause corrosion. But let's go to galvanic. What happens in galvanic corrosion? There's what you call a release of ions. Actually, me and some colleagues, we published a pretty nice review paper. We collected all the papers that we could find on titanium release. And that's what happens, is that there's some kind of galvanic, bacterial, wear, whatever you name it, that happens there, and it causes the implant to corrode and release some ions into the peri-implant tissue, the lymphatics, and even distant. Okay? So, do you know what corrosion looks like in somebody's mouth? Anybody has any idea what it looks like? Yeah, inflammation, but rusty nails. And this is my work, by the way, okay? Everything I show is what I did because I was a big titanium guy. That's a case that I did. Came back a few years later, probably 8, 9 years later, so we could, so there were some problems. You see the implant here failed. I had to take it out, it was loose. And all this is corroded. Here's another case of mine. The crown got loose. She came back to tighten it. When I take it off, I have a ring of corrosion here. This is the abutments, and this is the bridge, because this was like a hybrid. So it was cemented here, but it was screwed in the back. But look. That's corrosion in somebody's mouth. I love this slide because when I go to the conventional guys, I show them that, and that kind of, they drop their guard. They're like, oh, yeah, I see that a lot. I just wipe it off. I say, I used to do that too. I used to see that and wipe it off and put it right back in. Like how the hygienist polishes the old black amalgam, and then she lets the patients go. That's what I used to do too. And that's a problem. That's a symptom of manifestation of a problem. And bacteria doesn't really, plaque doesn't really attach well to zirconia. Therefore, you have less bacteria. So studies have shown, multiple studies, but this is the one by Rasparini, where on titanium surfaces, you tend to have more spirochetes, and on ceramic surfaces, you have cocoids. And we all know that spirochetes are more virulent. And we also now know that the material changes the phenotype of the bacteria that's around the implant. So you can have bacteria that are not virulent, that are not a problem. Once they get exposed to metal ions, change and become virulent. So the immune response, again, I'm going to go through that fast. The ions get released. The macrophages come in big numbers. They become giant cells. And then you start having an increased activity of osteoclasts, because inflammation will always activate osteoclast activity. So the ion release causes osteolysis, cytotoxicity. Then we have peri-implantitis, and ultimately we have implant failure. The soft tissue response is a lot different. Look, for example, here. Consecutive implants, black triangle at delivery, and it slowly closes itself with no intervention, no surgery. I don't set out to have these kinds of issues. But every time you're going to have these kinds of gaps around ceramic implants, you're likely going to have a resolution of it by itself. You don't need to go and do soft gum surgery unless they want you to do it. Osseointegration. We know they osseointegrate. There's some of us in the room here who have ceramic implants in our patients for 10 years already. We know they integrate and they can be successful. So there's no question about it. It happens. Okay, so why does it integrate? Because the surface, zirconia surface, is very wettable, is bioinert, is highly biocompatible, and the material, the implant material, is stable. It doesn't break down. It doesn't release ions. It doesn't create inflammation around it. How many times do you have these failing ceramic implants, but around it is clean, but it's failed for other reasons? There's no pus. There's no, sometimes there's no inflammation. The implant is just loose. So again, it's the material. And of course, and this is another topic for another day, there's all the host factors, the systemic factors. So I go to these facts. These are just surfaces, how they're being treated to be rough, to allow the bone to oppose on them. The treatment of the soft tissue surface versus the treatment of the bone surface. The bone surface should always be rougher. The soft tissue surface should be a little smoother, but slightly rough. That's why if you countersink that part of the implant, I see people do that. They go and countersink this part and put that in the bone. You have bone loss around here because bone cells do not like smooth surfaces. Bone cells require a certain roughness. So when you countersink that soft tissue collar, that smooth collar in bone, you get dieback of bone. I went to a lecture somewhere and a guy was presenting this and he says, well, ceramic implants are not any better because they also lose 1.5 millimeter of bone the first year. I say, sir, you countersunk the smooth surface. That's why you're losing bone. You're not losing bone because it's the same as titanium. But again, that's what we see out there. Okay, you see the difference between here and there. Okay. And that's a slide that really illustrates what happens. On a ceramic implant, you have a bone to implant, direct bone to implant apposition. On a coated implant, you have the titanium inside, you have the HA in between, and then you have the bone outside. And when the HA starts to break down, that's when you have a separation, and then you lose your implant also. And when it breaks down, the metal gets exposed, the corrosion starts, and you have a problem. And if you wanted proof that they integrate, here we are. Anybody has tried to remove a ceramic implant? Especially when they fracture and you have to take it out. It's tough because it really also integrates. So I'm going to show a couple clinical cases. This is a case of a premolar. So place the implant, again, leave the smooth colors at the supragingival or at the gingival level. Restored it. Actually, that was a margin unprepped. This system, you can prep the margin. Not all of them you can. And did a crown. Actually, this case, this person had a composite filling here. So the first, I was like, well, I'm just going to restore it and leave the white so that, didn't like it. So she came back, we prepped it, and we did another crown, and we put that at the gingival level. Okay. This is another one-piece implant. Like I was saying, most systems always start one piece. Anterior, 24-year-old patient, broken root, extract, immediate placement, allow it to heal. That's at the time of impression. You can see the soft tissue, very stable. This is stuff that is very difficult to see around metals. Okay? And then it's restored, crown number 7. No gaps, no discoloration because of the material that we're using. Now, this case now is 9 years old. That was one of my first ceramic cases. And this lady came and she had had for many years and a partial at the top. She decided that she wanted to do something about it. She didn't want to wear those things anymore. complain of always having a metallic taste. You wonder why? So we went in. At the time, there were no two-piece implants on the market. So we had to figure it out. So one piece, the system had no guided way of doing guided surgery or anything. So what we did here, we placed the implants, and in between the implants, we placed some temporary mini implants to support the denture so that it doesn't sit directly on the implants. Had to be creative a little bit there. The process is just like you were making a denture. Okay, so you just mount, you have to mount your models, do your try-ins, impressions. In this case, I use a little bit of digital. We did the models, scanned the models, designed the prosthetics with the CAD. That's the mandibular design, try-in of the zirconia framework. You see the cutback here. The cutback here is because we're going to put porcelain on top to get good aesthetics. And you can see zirconia. That was in 2012, I think, 2012, 2013. I did this case. And zirconia has gotten a lot better now. It used to be very, very white, very difficult to cover. And then, in this case, the only option was cementable, of course. Oh, by the way, I want to share this with you. This is a decontaminant. When you're trying to cement ceramic to ceramic, or ceramics in general, you want to use IvoClean because it removes all the contamination from the zirconia. Because zirconia has free ends, and it tends to attract phosphates and things like that occupy the free bonds. So when you bond, the bond is weak. So you always want to do a clean and an etch so that you get a good adhesion. So we took her from here to there, and that's what she looked like at the end of the treatment. Things got a little easier now. I got two-piece, I got screws. The screws are metal-free. I really like that. This guy comes in, totally hopeless dentition. We have to extract all the teeth. Yeah. And in this case, we do an immediate placement. We let the guy heal. He didn't wear any dentures over that. He said, I'll stay like that. I said, okay, no problem. Came back, same thing, wax up, mounted, just like I showed the case before, try-ins. And what's nice, and that's a Xeramex implant, by the way. What's nice with this, Xeramex has pegs where you can test the stability of the implant. So you can use the Ostel device, you put these pegs there, and with resonance frequency analysis, you can test if your implant is stable enough to be restored. With the one-piece implants, we used to do that with a perio test, which is also a very good tool. But the RF analysis is extremely well documented to be reliable to determine how stable an implant can be before you restore it. So you look for certain values. You look for 65 and up. And once you have those readings on each implant, you're confident that the implant is well integrated and that you can restore it. And that's what we did. We did two hybrids, one on the up, and that's what we have. All metal-free from the root to the cusp, and we give him a night guard also. Tons of hardware, and that's what it looks like at the end. This again is one piece with a Strawman, similar situation. Completely compromised dentition on top. The bottom, some teeth can be saved, but a lot of work needs to be done. But this patient's priority is to address the upper teeth, so upper jaw. So we plan the case. Now you have planning software that has some of these ceramic implants in the library. Make a surgical guide, go into surgery, place the implants, give her a temporary with a soft reline. Then we make a second temporary, a fixed PMMA temporary for her to wear for a while to get used to having fixed teeth again, and never go straight to ceramics. Then we start designing the permanent, again, digitally. And this is what we have. We made it into 3 sections. That's what it looks like on the model. And that's the final product. Again, that's the upper. Now we're now working on the lower. So when you look at this, this is what we have done. We have gone from to there. Okay? And That's probably not applicable to all of us, all of you guys. I always say people, now you have an option. You can still want to do this, that's fine, but you also, this works. So, this is a little bit an hour, 50 minutes is very difficult to give you all the nuances about everything. But if some of you want to learn more, yesterday I ran into a couple people who wanted to get some training or learn more. I've restarted teaching surgery, and the good thing in this case is that we can now do this in the US. North Carolina is one of the few states where if you come with a US license, you can do a training surgery on a live patient. So this course is in October. We have the support of Xeramex for this particular one. And with my good friend, Dr. Chris Phelps, probably some of you met him in New Orleans. So we'll provide patients the implants, and you can come in and do a surgery on a patient. For those of you who haven't done surgery yet and want to learn how to do surgery. So that's an option. And we always have our Congress every year. The next one is in Las Vegas. Hopefully we'll be able to no longer wear masks and travel comfortably. And that will be in May. And it's the 10th anniversary. It's been 10 years of this academy. 10 years we've been passing the word. 10 years we've been rowing against upstream. I know IAOMT has been doing it for 35 or 40, so you've done a lot. And it's thanks to associations like yours where this association is able to express itself without feeling the wrath of anybody. So, if you have any questions, send me an email or whatever. There's many ways you can reach me personally or reach the academy or send me an email with your questions. I'll be here all day today. I'll be here tomorrow. And I'm around, come and ask questions, challenge me. I love to be challenged, So thank you very, very much for your attention. And thanks.